Hello, everybody. I'm Dr. Riyad Ben Tamim. I'm consultant reproductive medicine and infertility with NOW-fertility. I'm pleased to host this NOW-fertility Connect event and to direct it. I'm pleased to have the present panelists. So Dr. Nicholas Darazi, who is our fertility consultant, Miss Julia Young, who is a fertility nutritionist, Miss Claire Ines, who is a nutritionist and a lifestyle coach. Miss Cassie Testino, who is a fertility doula and founder of IVF Support. And I hope Dr. Andreas Magila, who is our fertility consultant and reproductive medicine consultant, will join soon. So the objective, as you know, of this Connect event is to ask and answer fertility-related questions, to help our patients gain practical tips, to receive trusted guidance from an expert panel, to connect with NOW-fertility consultants and other fertility professionals. So please, if you have any questions during the event, add these questions to the chat. We will start by the first question asked by our patients. So why has polycystic ovary syndrome changed its name and why it is important? We know that recently there was a change, a global change in the name of polycystic ovarian syndrome, more preferred to be PCOS, polyendocrine metabolic ovarian syndrome. So what we remark is that we omitted the cysts and we captured more endocrine, metabolic, and ovarian dysfunction. I would ask this question to Miss Julia Young as PCOS and fertility nutritionist. So the floor is yours, Julia, and then I will ask also this question to Ms. Claire Ines.
Yeah, brilliant, thank you. So this has only happened recently in the last couple of weeks. There was a major report in the Lancet journal announcing the name change to polyendocrine metabolic ovarian syndrome, which is a bit of a mouthful. But really the reason behind the change is it's not simply an ovarian condition. And many women with the condition don't even have ovarian cysts. So it's all a little bit, the previous name of polycystic ovarian syndrome is a little bit misleading. Now, these polycystic ovaries are not true cysts. Actually, it's about having multiple follicles on the ovaries. And some women with PCOS or PMOS don't have polycystic ovaries at all. So that old name focused on the ovaries, whereas the condition really involves a much wider metabolic and hormonal dysfunction. So it's now more widely understood that PCOS or PMOS commonly involves things like insulin resistance, so blood sugar dysregulation, inflammation in the body, androgen excess, so excess of these androgen type hormones, potentially disrupted ovulation, fertility issues can be common, being, as I said, a metabolic condition, stress hormone involvement, and also we know it can be associated with gut and thyroid issues as well. So why it matters, why it's important, the name change, I think, name changes shape conditions, how conditions are really understood and treated in the medical industry. And for women, for many years, women were told that PCOS was mainly a reproductive issue or simply an ovarian problem. But in reality, we've now seen from this paper and from the research that it's a whole body, as I said, metabolic and endocrine condition, and it can affect things like fertility, your energy levels, your mood, weight regulation, skin health, long-term health, and pregnancy outcomes. In terms of a kind of, I guess, fertility and nutrition perspective, this shift is important because it reflects what many of us in the industry have worked on in this area and focusing more on looking beyond the symptom control and addressing those underlying drivers that are contributing to the condition. Certainly the name change doesn't really change how I work with my clients, as I've always worked on the root cause of PCOS or PMOS and supported the drivers. But hopefully, in terms of the medical industry, there'll be more focus now on those other drivers that are involved. So I think it is an important change, and hopefully we'll see some good come from it.
Okay. Anything to add, Claire Ines?
Yes, absolutely. So I think I agree with Julia. It is an important change, and it's really quite validating for the kind of hundreds and thousands of women who've been asking for some help over the last hundreds, possibly thousands of years. I mean, for decades we called it polycystic ovary syndrome, which was always ambiguous and not particularly accurate. It was never cysts, it was follicles. So it was fluid-filled sacs of potential that essentially got stuck in the waiting room because they never got the signal to kind of develop. But the shift we're seeing now is not just linguistic. The names carry instructions. So when we called it PCOS, it brings to mind, an ultrasound of the pelvic bowl. But when we call it a metabolic condition, that tells us, we need to look at the blood, the insulin, the inflammation in the entire human being. And that therefore moves the conversation for the women who are suffering from this condition out of the ovaries and into the endocrine system where it belongs. So many women I've worked with have been sat in doctor's office at 16 years old with terrible menstrual cramps, unable to get out of bed. And they've been told, go away and just lose weight, as if it was a matter of willpower and as if it wasn't the syndrome that was contributing in the first place. So it's finally, for a lot of women, it's very validating because it's admitting that they were never failing at their diet. They were just almost, it was like trying to build a house on shifting sands because the foundation was metabolic in the first place. They were told to move more while their insulin was silently screaming, and they were told it was their fault while their biology was in some kind of storm. So for my clients, it feels like almost a kind of an end of the gaslighting of this label that's been going around, and it allows them to stop trying to starve themselves into fertility. And that's what I think is going to come of it very, very quickly. This kind of starving, trying to lose weight, 1,200 calories a day, shaming. It means that we're trying to stop fixing a broken ovary that, and we start creating a metabolic environment where the egg is actually able to thrive. And that's the difference between treating a symptom and reclaiming their life for some women. I think it's very significant indeed. Would you agree, Rehad?
Yeah. So, as you know, yes.
Riyad, may I ask, please, do you find more or start finding in your practice more of these women who particularly who had insulin resistance coming to you with GLP-1 treatment like Ozempic or Mounjaro? Do you start seeing those patients coming with such a treatment?
Yes. Look, I try to be a little bit classical, let's say, that is beginning with the diet, beginning with exercise, with lifestyle modifications as a first step. The second step would be glucophage or metformin. But many of my patients would be resistant to glucophage, metformin, inositol, insulin against insulin resistance. But as a third step, I see more and more patients, especially obese patients, that are going to GLP-1 treatments. And here it's an explosion. Here I work in Saudi Arabia with patients taking these injections. There has also been added now the same treatment oral. I received 1 or 2 patients taking these not only injections, but also oral medications. So things are, there is an evolution or are progressing. And even I have some patients that go to surgery. If all these steps are not, do not give the result, they are going to gastric sleeve or to bypass, even sometimes to bypass in extreme obese patients. So yes, I think these new medications will have certainly a big part in the treatment in the future, and is taking even a big part in obese patients, diabetic patients.
Julia, among your practice for whom you offer nutrition services, do you find the patient coming with those kind of treatment?
I do some. Obviously, we know it's contraindicated infertility, so I'll have some that will be taking them, and then obviously they have to have their washout period and stop taking it before they're trying to conceive. So we have to be careful around that. But I think, I mean, I agree. I think it's these are medications that are just going to grow in terms of, you know, more and more people are going to use them. Absolutely, absolutely. But I think the nutrition and lifestyle piece around it is really, really important. We know there's research on weight regain after coming off them. People don't necessarily want to be on them for the rest of their lives. So real careful management about their diet whilst they're on them and when they come off them, I think is really, really important. And also, again, I think it's important to address the root cause as to why they need to go on them in the first place. And if we don't address the behavior change around the food, the eating, etc., that may be associated with it. I know with women with PCOS it is harder, but I think that's an important piece to include when they're taking these medications and when they're coming off them as well. But yeah, it's just going to grow, I think.
I think for many years we used the Rotterdam criteria, as you know, for the diagnostic of polycystic ovary syndrome. And even with the Rotterdam criteria, we were based on the presence of at least 2 of 3 criteria: the irregularity of periods, the androgen excess, and the ultrasound aspect of the ovaries. But we find many patients, and they come and we do an ultrasound and the ovary is normal. And there are no cysts in the ovary, and there is no polycystic aspect of the ovary. So this, I think, pushed a little bit to rethink about the definition or about the guidance about polycystic ovary syndrome, and to stress more on the metabolic and endocrine as a polyendocrine abnormality and as a metabolic insulin resistance, androgen excess effect. So things are changing, and perhaps this change in the pathophysiology, let's say, will have certainly an impact on the therapy, on medicines.
Indeed.
Okay. So if you have any questions, so please put them on the chat. I will go to the second question asked by our patients. So could autoimmune antibodies be causing my miscarriage? We know that in the investigation of recurrent miscarriage especially, there is a part on autoimmune antibodies. And I will leave the answer to Dr. Andrea and Dr. Nicholas to give us more information.
Yes, actually, we have women with different autoimmune diseases, which have a huge impact also on the pregnancy outcome. So the quite common disease, which is diagnosed in women who had some miscarriages in the past, is antiphospholipid syndrome. It's an autoimmune disease where we have some antibodies, anti-cardiolipin antibodies, and they have impact on blood vessels during pregnancy. The problem, of course, is inflammation and changes in the blood vessels, especially in the placenta, which then will cause some microthrombosis in small vessels, which will impair the blood flow through placenta to the baby. And then the final results are miscarriages. So fetal losses before 10 weeks or also above 10 weeks, intrauterine fetal death, intrauterine growth restriction. And these women also are at higher risk for deep vein thrombosis or during pregnancy or even before or after the childbirth. Another common condition is lupus. It's a systemic disease which is mostly diagnosed in early age in women who are in reproductive period. And mostly these women, of course, they have changes in their blood vessels, and the final result is can be high blood pressure and kidney damage. Of course, they have also they need to take special medications, which could be teratogenic during pregnancy. So for these ladies, we need to inform them first that their disease should be in steady state, so no flare-ups. Then we should check which medication she takes and to change them for those medications which can be taken during pregnancy. And unfortunately, that they can also experience a miscarriage. On the other side, we also have women with thyroid gland issues. So the researchers didn't confirm that these antibodies against thyroid gland will cause miscarriage, but they can have a huge impact on thyroid gland, which has to be more active during pregnancy to produce higher level of thyroid hormones until the thyroid gland in the fetus is developed. And this can have an impact on the pregnancy and can cause pregnancy loss. So when we have women with recurrent pregnancy losses or with infertility and also failed IVF treatments, we should think also about these autoimmune diseases and to do special blood tests which can confirm the presence of these antibodies. And of course, based on diagnosis, then we can also help them with special treatment. Like in antiphospholipid syndrome, women need to take low dose of aspirin and low molecular weight heparin, which will prevent this microthrombosis during pregnancy and will help to achieve a live birth. Of course, this pregnancy is at high risk for many complications, but with this treatment and of course with additional checkups by specialists, we can help these ladies to deliver a healthy baby on time.
Anything to add, Nicholas?
No, in fact, no. It's we wish not having too much from these cases because they are really not difficult to diagnose because we have the history and the recurrence who orientate us towards this diagnosis, but very more difficult to confirm the diagnosis and more difficult, not even difficult also for treatment because steroid and low dose aspirin or heparin, but definitely what is the most unknown is the prognosis. Who will get over it and have a normal pregnancy, and which pregnancies will recurrent in their miscarriage. That's it. Andrea explained everything.
Yeah, I agree with Andrea. So we did with in NOW-fertility some recommendations, list of recommendations taken from the ESHRE recommendations. So I think you can find this on our NOW-fertility site for recurrent implantation failure and recurrent miscarriages. I agree that the autoimmune investigation must be done, and these are the recommendations also of ESHRE. Concerning, as said Andrea, the antiphospholipid syndrome, so anti-cardiolipin antibodies, looping anticoagulant, anti-beta-2 microglobulin antibodies, I think we have to search for this because sometimes we find. For the lupus anti-nuclear antibodies and anti-DNA antibodies, I think we have to search because even lupus and antiphospholipid syndrome may be joined together. We can have an antiphospholipid syndrome secondary to the presence of lupus. For the thyroid, we know before that the thyroid antibodies may cross the placenta and cause problems to the thyroid of the fetus. They may cause polyhydramnios, they may cause growth restriction. So the thyroid investigation is very important with the anti-thyroglobulin antibodies, anti-TSH receptors. So these are very, I think they must be searched. I will add something that we know and sometimes we forget is the indirect combs. So we know that for patients that are rhesus negative, they may have an alloimmunization, and that might be a cause of recurrent miscarriage. So when we have, in case of recurrent miscarriage, especially a patient with a blood group rhesus negative, it is better to ask for irregular antibodies and for indirect COMBs. So these are some recommendations, and this will give us a therapeutic issue based on the salicylic acid aspirin, low dose aspirin, and low molecular weight heparin. The question of corticosteroids is a question of debate. Many of my patients will ask, is there a place for a corticosteroid prednisolone treatment? It depends. I don't know, Andrea, do you give some these treatments in case of presence of autoimmune antibodies?
Yes, I have some patients who already took this low dose of prednisolone, especially in the first trimester. Maybe then they continue also later. We have also patients with like Addison disease who need to take corticosteroid therapy during the whole pregnancy, and the final. So the experience was always positive. We didn't experience any important changes in fetal development or fetal growth, and mostly they delivered on time, healthy babies.
How about laboratory findings, accuracy, Riyad? Accuracy of laboratory findings?
It depends on the laboratory and the certification of the laboratory. But generally, if I find a high level, high percentage of these autoantibodies, they generally are confirmed. I sometimes repeat the test when I find one cross or weakly positive antibodies. So I try to recheck, because there is an implication. We will give low molecular weight heparin for the whole pregnancy, and this may cause sometimes some bleeding, some abnormal uterine and vaginal bleeding. So if I find 3 crosses positive or very high level, yes, I treat. If sometimes fairly positive or mildly positive, I will try to repeat and even to take an advice of internal medicine advice.
Thank you.
Okay, so let's move to our third question for Nicholas. So married couple living in 2 different countries, can sperm be transferred from one country to another? So I think we deal with these situations for the transfer of sperm from one country to another, and we have some clinics that accept.
Yes, transfer can be done, but all depends also from the regulation of each country.
Yes.
And of course, it should be done through an accredited gamete transporter, experienced also, not only accredited. And of course, with a complete coordination with a team of care from the clinic where the sperm is to the center, the recipient center. It's full of details, it's full of regulation, but expert can do it, and we accomplished some successful transfer of all gametes, sperm, egg, and embryo.
Yeah. I think it is our everyday challenge, because the laws and legislation vary from one country to another. And we find difficulties in transferring. It is possible. Some clinics accept. It depends on the country, on the law. Some clinics do not accept. So we have our partner clinics that refuse to transfer or to acquire and get semen from other clinics. But some accept. But there are conditions, and we must respect these conditions according to the laws. There are consents to sign. And we have our biocourier that help us in this situation. So let's say it is possible, but under conditions.
Riyad, I should emphasize about the importance of having a good communication and good understanding, first of all, from the couple, because, and this is the importance of the concept of now fertility. We should explain to them well how things will do with respect and regards to the many parties involved, because legally we are in the middle, but we don't have any direct responsibility. So I noticed through our experience, the couples who understand well the limit of the service, they know very well how to explain to the clinic where their gamete is, because I can understand, first of all, it's a new service. Maybe this clinic is not used to do transportation of the gamete who are in their lab. So we should understand this, and the couple and now fertility backup can help to understand, to accomplish certain form. And of course, there's sometimes personal and subjective feelings when you are taking something from someone. We should also understand this, that it's not a lack of competency or whatsoever, but it's only for to accommodate patient, because finally it's their own, it's their gamete of their own. And the same thing apply to the recipient clinic, who should inform and aware the couple in case there's any additional details concerning the authority at the airport, and till receiving the lab and the team be ready, etc.
Yeah, it is a challenge in all these steps, from
Absolutely.
the, let's say, donor clinic, recipient clinic, the law, the legislation, even the religion. So many things enter in the indication. So we try to do our best, but sometimes it is difficult. Many clinics sometimes refuse the transfer of gametes.
Just for the audience, that now fertility developed a specific policy regarding transportation of eggs to Egypt. Why? Because the law was not, the operation never happened in Egypt. And what they were afraid about in Egypt, even so they are very professional and very high standard internationally, in Egypt, they were afraid of manipulating gamete or egg donation or something like this. Our policy included, to reassure the Egyptian, our partner in Egypt, include that the couple, the married couple, should accompany on the same plane the international professional accredited carrier. So there was at the same plane the gamete of the couple, and the couple were taking the same plane and who arrived at the same time, and of course with all the security measurement. But it was the first of a kind, and we developed a special policy regarding this to make the service possible.
Okay. Thank you, Nicholas.
Can I just ask a silly question? When you say gamete, does that mean the sample?
Gametes, these are semen or eggs. So the gametes,
okay. So it can mean
because
both.
Yeah, and even we have sometimes transfer embryos. So we have some embryos now. We have some challenges. We are trying to transfer an embryo from I think North Cyprus to Greece or to England, and there is a problem of age, because in some countries, after a certain age, you cannot do IVF there. So there is also the limit of age. Apart from the religious and legal issues, there is also an issue of age. Sometimes the eggs or gametes or semen is frozen and embryos are frozen, and you cannot transfer them because in the recipient clinic, the age limit is over.
Face plank. So just to be clear then, can gamete mean sperm, egg, or embryo?
No, gametes are sperm or egg. Embryo is after embryo. The fertilization. The embryo is the result of the fertilization of the egg by the sperm. When we say gametes,
I've never heard of gametes before.
Either semen or eggs. spermatozoa or eggs. Okay, so we will go to our fourth question asked by our patients, and this is a very common issue. We meet it every day in our website and in our chat box, let's say. It is the question of AMH age. I will just read three questions asked by our patients. I am 40 years old with an AMH low 0.08 nanograms per milliliter. Would I be able to have IVF with my own eggs? So this is one question. In the same sense or direction, what are the options for treatment for a woman aged 53 years old? I am 45 years, my husband 63. Are there any treatments possible for us? So to summarize, low AMH, do we continue? Do we do IVF or not? Age limit, are there age limits in our clinics? Can I do IVF with my own eggs given that I have a low AMH? So I will ask Andrea, please, to begin the response, and the floor is open for the other consultants.
Thank you. Yes, women of advanced age, about 40 years, and if they have very low AMH by Bologna criteria, they are poor responders. So it means that we can expect that they might produce some mature eggs, but of course we need to inform them first. They will need very high dose of medication, many cycles of treatment, high risk for cycle cancellation because we monitor the response of ovaries during treatment, and we might not be able to retrieve some mature eggs. So if they want to try, if they, and after they are aware of this information, to produce some eggs for IVF, of course we can try. On the other side, we know that the genetic material in people of advanced age is different. So also if we collect mature eggs, this is not a guarantee for successful pregnancy because there's high probability of genetic malformations in embryos. So the embryo development can stop in the lab before the embryo is transferred to the uterus, or when after embryo transfer, it might not survive in the uterus. So it might not come to the positive pregnancy test, or later a woman can experience miscarriage. So for women at advanced age with very low AMH, it means poor ovarian reserve, the better outcomes we can expect with donored eggs. Also, women might have already irregular periods, can be in premenopause. We have also women with premature menopause who will come to us with infertility issues. And of course, we need to explain them that there might be some options, but of course, we can't guarantee successful pregnancy. And we need to inform them about the other option to use donor eggs, which can help them to achieve successful pregnancy in shorter time. And on the other side, we should not forget also about male partner age, because also the sperm will, there are some genetic changes also in the sperm in male partners with advanced age, which can cause the early miscarriages. So we are mostly really concentrated on women age, but on the other side, we need to think about also on age of male partner and possible changes in genetic material in sperm.
Yes, absolutely, Andrea. So I always try to simplify a little bit this for patients, saying that the impact of the woman is about 80% to 85%, and the impact of the semen is about 15 to 20%. Now the question is that we use it sometimes to refuse or to say to patients that the chances were very low if we had an AMH less than 0.5 nanograms per milliliter. This has been changed a little bit during the last years. saying that we cannot say 100% that we have to refuse and to say to the patient, you will not get pregnant. And if you see even on Facebook or on Instagram, some patients say, look, I became pregnant, or some doctors say, I obtained the pregnancy in this woman that has 0.08 nanograms, like the question I said. So in my opinion, we have to try at least one stimulation. What will happen? Either there will be a bad response, poor response, so we will cancel the cycle, and the patient would understand really that her ovaries are not producing the right amount and the right quality of eggs. So if we try, we must not lose time effectively, but one or two stimulations just to convince the patient may be one issue. And there is the option for egg donation, and even sometimes for semen or sperm donation. What do you think, Luciano?
Can I, before Luciano?
Yeah, please, Nicholas.
Just to say, I totally agree with you both, and I will summarize just what you are saying, but in one word, all depends about the profile of patient. You see, since the beginning, because the patient, particularly we are speaking in front of fertility coach, when you see the couple, you know the one who did already the research and who know about low MAH, poor diagnosis, low antral follicle count, and all the scientific criteria, which are not very encouraging for a good prognosis. We know all about it. But after all, we are in front of couples, and they want results. And particularly for ladies, some of them, and this is what I meant by profile of the couple, do not stick and do not understand too much the laboratory findings, because the laboratory findings and NMH may change in a few years from this level to this level. That's why for those who are convinced about the science and the science finding leading to a low prognosis, this couple will ask, and of course we will encourage with a low poor ovarian reserve to go through egg donation. Otherwise, when there is any single doubt about the result, about how come a laboratory test will be the judge if yes or no, or guide me directly to fertility, here I totally agree, Riyad, to go through a stimulation cycle and let her see and feel her own findings after stimulation. At this time, she is convinced. In case we have a good surprise, everyone is happy. In case we don't have a good surprise, she is convinced because she tried, and now she can go directly through the option. Sorry to intercept before Luciano, but...
Yeah, I entirely agree. I think there are two issues. One is patients' expectations. So what is the level of expectations when they embark on treatment? And the second is to make them understand that even if we collect eggs, the available eggs, even if good quality, may not be competent to be fertilized and form an embryo. So if patients with a low AMH have realistic expectations, they accept that there is no guarantee from stimulation. And even if we collect eggs, the harvested eggs may not be suitable for fertilization, or if fertilized, may not reach the stage of a healthy blastocyst, then there is no, and there's no reason for them not to start. So I think if we can manage their expectations, and I always say to my patients, yeah, I've just actually, the reason why I was late, I was just finishing a consultation with a couple in Montenegro. They have low ovarian reserve. She has very low ovarian reserve. And we discussed the options, if continue with stimulation or not. But we see this in clinic every day. Some couples are prepared to take the risk, to take the chance, have realistic expectations, know that the cycle may be cancelled, and of course understand there may not be embryos. In that case, there's no reason not to do it. But at one point, of course, we need to be able to say, this is the end. You cannot continue anymore.
Let me just add two small remarks, Luciano. So the evaluation of the ovarian reserve is not only based on AMH. Sometimes we must include other factors, FSH, age, antral follicle count. That would give us some idea, especially the antral follicle count. Also telling the patient that perhaps we have 2 or 3 follicles on the antral follicle count, but how many will grow, how many will, the percentage of fertilization, and the quality, the genetic quality, will there be chromosomal abnormalities in the embryo. So all this will enter into account. Let me say finally that on our website, NOW-fertility website, we have the list of our partner clinics with the possible issue of egg donation if necessary, and also with sometimes the age limit for going to IVF with own eggs. Let's, if you want, move to the next question. So what question should I ask my consultant when I first meet them? So I will ask Claire, Ines to kindly respond to this question. And if Cassie is here, please also after Ines.
Sure. So the first thing I would suggest anyone ask their consultant is, based on my specific history and my specific blood work, why do you recommend this protocol for me personally? So this is about us ensuring that it's not just a kind of standard clinical response, that they are very aware of your unique situation. And it's also really useful for any couple or women to know why a specific protocol has been chosen for them, because there's no bog standard, there's no typical fertility client, there's no typical IVF client. So what do you recommend for me and why, I think should always be the best question. And then even something about benchmarking. So obviously it's always good to set expectations with people. A woman who is 25 and hasn't had any previous issues is likely to have better results than a woman who is 44. So I always think hearing that from the person who's in charge of your care is going to be really, really useful as well. And then the last one, if this protocol doesn't yield the results that we need or we expect, what is plan B? So we want to make sure that your team have got your back and they're already thinking 2 steps ahead, because they obviously want you to have a baby as much as you want to have a baby.
Absolutely. So let's move please to the next question. Where is IVF for family balancing available? So I will ask Nicholas, because he helps a lot with the gender selection for family balancing. So I will let him answer this
family
question.
Balancing is available in the Middle East, basically. There is no law who prohibit family balancing in the Middle East, while in Europe it's not service not allowed, and we are receiving more and more patients coming from Europe to benefit from this service that we offer at NOW-fertility since 3 years almost ago, with a very high standard clinics in Saudi Arabia and in Egypt. So, and we are having very good results. Many of these families are happy to get, with the help of God, of course, in the Middle East, we do insist upon this, the desired sex. I should say also, it's not easy. It's not easy, and it's not a guaranteed results, of course, for sure, because usually there is a low percentage. For example, in the family where we have girls and we are asking for a boy, if we, after doing the biopsy of the embryo resulting from the IVF procedure, if we have 10 healthy embryos, there is a majority of this embryo female, for example, 6 or even 7 female, for a minority male, the sex, desired sex, and it go vice versa. I don't want to say male or female, but usually family who are just, I want to say through this message that it's not easy and it's not guaranteed, because we only operate through usually the lower number of embryo, and this suppose that this embryo, this low number of embryo is healthy. Is healthy because sometimes we get the desired sex embryo, but as we don't have many embryo, the embryos that we have may be not all of them healthy, and the whole procedure may result without transferring an embryo.
Yeah.
So this also, at NOW-fertility, we take our time to explain to couples that we will help, that technically it's feasible, this service is offered, and it's done in its highest standard, but there is no guarantee in advance about neither how many embryo we will get, neither the sex of this many embryo, which sex, and neither if the desired sex embryo is all of them healthy to transfer and to complete the procedure, or maybe not having healthy at all, and it will be a difficult decision not to transfer any embryo and what to do with the other.
Absolutely, Nicholas. I had an experience just last week with what you are talking about. So I had a patient, 42 years old. She had 4 daughters, and she wanted 4 daughters for cesareans, and she wanted to do IVF with gender selection for family balancing. So I stimulated her, and fortunately, I retrieved 4 eggs. 4 eggs were fertilized, and I obtained 4 embryos. Let's just to stress that when doing the gender selection and identifying the sex of the embryo, we did like a mini PGS or PGT for the other chromosomal abnormalities. And unfortunately, the 4 embryos were abnormal and I could not transfer. So there was a trisomy 18, there was an abnormality in the X and Y chromosomes, there was abnormalities in sex chromosomes, and for the male fetus, let's say, there was a deletion, Q21 deletion or something like that. So this situation is more frequent, and I think it's also better to test for the other chromosomal abnormalities, at least for the chromosome 21, 18, 13, and for the sex chromosomes. And the other issue is to tell the patient that probably it is poor possibility or low possibility, but perhaps you will not have the sex desired for the 4 embryos. You may have either for girls or for boys. It is a possibility that has to be discussed with the patients. I would just add that in our partner clinics, as you said, in Saudi Arabia and in Egypt, but I think also in UAE, Luchan, we do gender selection and family balance.
Sorry.
Okay.
And yes, I will add something, Riyadh. When first couple ask for this kind of services, I highlight particularly in the Middle East and for the Middle East population that yes, the service is available, but as its name say, it makes part of assisted reproductive technology. We are assisting. So when you are assisting, you do your best, but you don't have a guarantee. You don't know the result. So to make things simple, easy, and even legal.
Yes. So let's move to our last question. Is there different nutritional advice for after embryo transfer and before embryo and before the transfer? I think this is a very interesting question because I didn't think sincerely about it. Is there a special diet before and after the embryo transfer? So I will ask Julia first to answer and then Claire to add if she has some remarks.
Sure. So yeah, I suppose it depends on, are we talking about before fertilization and egg collection, for example, or just before transfer? I mean, obviously, a lot of the foundations will be the same, but there will be some differences, important differences between the two. Obviously, if we're talking about before fertilization, we need to focus on the male partner as well. So sperm quality is going to be really important, and also supporting egg quality. And then things like blood sugar regulation and generally reducing inflammation in the body. So as a kind of general guide, I would say, Mediterranean diet is a really good principle in terms of a way of eating, and it's very anti-inflammatory with lots of fish and vegetables and colourful fruit and things like that. So focusing on that pre or post transfer is really important, and just generally reducing inflammation. But we're also looking at supporting implantation potential. So that could be testing and looking at supporting the endometrium for implantation. So looking at vaginal microbiome, the uterine microbiome, and things that can impact that. So we know things like, obviously, the microbes in there that could have an impact. Things like stress can increase the more pathogenic bacteria. High sugar diets, again, associated with less favourable microbiomes, chemicals from the environment. So they're all things that can be worked on. And then I think looking at post-embryo transfer, nutritionally, yes, we're sticking to a lot of similar things. Often you see on Instagram about there are superfoods that can help with implantation success, or should you go and have, is it McDonald's fries or something like that? I don't think there's any particular foods. I mean, certain foods that support blood flow, like beetroot, high nitrate type foods, can be helpful, including those in the diet, but they're generally healthy foods anyway. I think almost if you're eating the same way pre-transfer, but then looking at maybe more of the lifestyle factors is really important. So think about your stress, think about your movement, your sleep, because obviously it's a very stressful time post-transfer when you're waiting for the result. So really nourishing your body and focusing on all of that can be really important. Keeping hydrated, and obviously the usual, obviously eliminating alcohol and caffeine and things like that. But I think, yeah, what you can do to support your lifestyle is equally important as well as the nutrition at that stage.
And you, Claire?
Yeah, I'm actually a bit of a fan of the McDonald's French fries after embryo transfer. I just think it's quite a fun little thing, just a little tradition. So I actually do encourage my clients to do that just for kind of old time's sake. In terms of like before transfer, we do know that the 3 months before an egg is ovulated is a really good chance to build up the mitochondria, really think about egg quality and the ATP. So for there, we're looking at antioxidants, healthy fats, and high quality proteins. That's really what it needs to come down to in the 3 months before egg collection and embryo transfer. And then afterwards, I like to just think about systematic stability. So just creating a nice, chill environment. So as Julia said, anti-inflammatory focus, definitely blood sugar management, and even just kind of nice, simple steps like eating warm foods, things like soups, stews, cooked grains, just to keep the blood flow directed towards the uterus, towards the digestive system, and not kind of working overtime to break down raw cabbage and the likes.
Okay, thank you. Anything to add from other panelists? Okay. So I think we arrived to the end of this Now Fertility Connect event. I would like to thank all the panelists that participated in this event, and I wish we will meet next month for another event. Thank you very much, and good evening. Goodbye.